Is there an estimate of, if you get COVID once today, what the chance of getting long COVID is from that?
Well, there are several studies, and the numbers vary, but in the beginning it was about 10 to 20%, and now
Oh my
it's much,
gosh, that's
it's much lower, 1 to 2%. I think that's a good estimate.
and what do we think the current prevalence of long COVID is if we look at, across society?
Renowned epidemiologist, he came up with a number of 5% for 2023.
I
5%
mean,
of
that,
the world.
that's massive. 1 in 20 people have long COVID. Carmen, welcome to the Clear Thinking Podcast.
Hello, Spencer.
So when COVID struck, after a little while, we began to hear about the scary idea of long COVID, that some people after getting COVID would have these symptoms that would last and sometimes be debilitating. And it was really quite scary for many people, but not very much was known about it at the time. Everything was being figured out. Tons of papers were coming out, but there was a lot of confusion. And today I know people who are still very concerned about long COVID. They're worried, oh, maybe I'm going to get long COVID and be sick the rest of my life. So today I want to explore with you, what do we now know about long COVID? How serious is it? Is it treatable? And so on. So my first question is about the definition, right? In the early papers, any symptom that people got that they experienced right after getting COVID that didn't go away would be sort of considered long COVID. Do we have a clearer definition now of what long COVID is?
Well, actually, long COVID is not a medical diagnosis. It was defined by patients already quite early, I think around late spring in 2020. The first patients reported that they have ongoing lasting symptoms. So long COVID is broadly defined as persistent symptoms following COVID. And these may be various symptoms and also maybe specific diseases in a few patients. Later on, the WHO, I think they were among the first to better define this, and they defined it as post-COVID condition, and they made a clearer definition based on the duration of symptoms and the severity of symptoms.
So post-COVID condition, which I guess is the formal diagnosis, what does it include? What do you have to meet the conditions of it?
So it is a condition which needs to last for at least 2 months, and it should start within 3 months after having acute COVID. It needs to impair you in daily activities, and it should not be explained by an alternate diagnosis. This is a formal definition. This is still quite broad, but that is a good working definition.
Are there any particular symptoms it has to involve, or could they be sort of any type of symptom? Because that seems so broad if we include every symptom.
Well, the WHO listed several symptoms which are very common, like fatigue or pain, but the condition is not defined by specific symptoms.
Is that unusual? Are there other disorders that we have that are like that, where there are not particular symptoms that define it?
Well, we have post-infectious syndromes other than long COVID, and that's actually a group of conditions with a lot of overlaps, but also with some differences. And in many of these conditions, we do not have clear diagnostic criteria, but it's more the coming together of several symptoms. And when there are specific constellations, it's called syndrome. So myalgic encephalitis or chronic fatigue syndrome is a variant of this. This has been known already for decades, and actually it's triggered by various infections, but also by SARS-CoV-2. That's what we learned. And that is a good example for such constellation of symptoms.
So did we learn that nearly every virus can give you a kind of post-viral syndrome? Or is it sort of unique to certain viruses like COVID?
Well, actually, we don't really know. What we know for sure are the viruses which can trigger such post-viral syndromes. The best known are Epstein-Barr virus, influenza, dengue virus, Lyme. So there are actually several, but we also have many patients who have a respiratory tract infection and then develop, for example, ME/CFS. And of course, in adults, we often do no testing when they are acutely sick. So we do not know the whole spectrum of infections which may trigger such syndromes. But actually, we think it's probably not the virus itself which determines the disease, but more the severity of the infection. So by having just a mild flu, you usually do not get such a disease. So it's usually a more severe infection which is required to trigger a post-infectious disease.
Is that true of long COVID? Because this might not be accurate, but I'd heard that actually there's not much correlation between the severity of the initial infection and whether someone gets long COVID or not.
Well, I think one needs to see what is mild COVID per definition. And that was originally defined as not developing lung disease or pneumonia. So mild COVID, at least during the first 2 years, often was made the people quite sick too. So it often lasted for more than a week. And there was still virus present in the second week. And that's already a pretty long and severe infection for the immune system. And what is special about SARS-CoV-2 is that it was a novel virus. So we had never had contact with this virus during our childhood days. Therefore, the immune system had more to struggle to get control of this virus.
I see. So severe, there's different versions of severe, but the original definition.
And that's probably the reason why we have quite frequent long COVID, this post-infectious symptoms, because of this new virus our immune system had to face.
I see. Now, with a virus like varicella zoster for chickenpox, it can kind of it can stay in your body, right? That's typical, that it sort of never leaves your body. It becomes inactive, but then it can come out later again as, maybe much later in your life as shingles if you have a weakened immune system.
Yeah.
With viruses like COVID, do they work that way where they can stay in your body? Or does your body actually eliminate them and any kind of post-viral syndrome is not about the virus still being in your body?
Actually, there's no definite answer to this question. In the beginning, actually, we didn't think that SARS-CoV-2 can persist at all. It was considered as an acute viral infection and a virus that we quite fast can clear, as with many other viruses.
Like a cold, right? A cold you typically
clear
out of your body.
a common cold. So, but then it became clear that at least in a subset of patients, we can detect the virus for quite a while. So there were several studies showing viral persistence, for example, in the gut, or in the bone marrow, or in the brain. And then I think in around 2022, there was actually a large part of the scientific community thinking that long COVID is most likely viral persistence. This view has changed. So now we still think that it may play a role, at least in a subset, but we know for sure that it's more than just a chronic viral infection.
And when they find it in the body, what do they actually find? Because there's confusion around, like, your body can have immunity, and if you check immune cells, they could show that you're kind of have immune cells for the virus for potentially a year or 2 years, but that doesn't mean you have the virus, right?
Yeah, but there were also studies showing viral RNA. At least they showed RNA, which does not necessarily mean that the virus is replicating. It may also be that it's silenced, but still there. Or there were other studies showing that there was spike protein detectable in a subset of patients. Actually, we did a study. There is a sensitive assay with which you can detect a spike protein in the serum, and we found it indeed in about 10% of people. But that was independent of long COVID or not. So we also found it in recovered. And in those who had long COVID, we also found no correlation with severity of the disease or with any specific symptoms. So we do not really know what this means.
So it could be that some people still have it in their body, but it doesn't affect them in any negative way. And it's still unclear whether it's actually contributing to long COVID or not. Is that right?
Yeah, that's a good summary. Mm-hmm.
It's kind of incredible that this it feels like such a basic scientific question. It's kind of incredible how hard it is to answer definitively. Why is that? Why is it so difficult to get to the bottom of that?
Well, probably it's because it's so complex, not only the clinical presentation, but also what we found biomarker-wise. So we found so many alterations in the immune system, but also in the nervous system, and we found inflammation in several tissues and impaired mitochondrial function and alterations in the microbiome. And so we have many pieces of a puzzle, but we still have no answer how this all belongs together, and if certain mechanisms play a dominant role in some people and other mechanisms in other. And so the current concept is that we face subgroups of different pathomechanisms, that the immune system most likely plays a major role. But as it's always in medicine, the genetic background also plays a role, and therefore this also influences the variations we see in the different mechanistic and alterations we find in patients.
So would a typical study that's trying to understand long COVID, would it say, okay, take some people who were diagnosed with COVID, they clearly had COVID, then they developed long COVID, take another set of controls that had COVID, but then they didn't develop long COVID, and then we're going to measure a bunch of biomarkers between the two groups, and we're going to look for statistically significant differences? Is that sort of how it's generally approached?
Yeah, that is the first approach, how you would do it, or how you are doing it. And then what is also a major question is the findings you have, do they anyhow correlate with the symptoms the patients have or the disease severity? And if you find such associations too, that gives you already a good clue that this may be disease relevant.
Right, because if the long COVID group had some trait that the control group didn't have, but it wasn't associated with worse symptomology, it might not be very meaningful. Is that right?
Yeah, it may be just an epiphenomenon. But for example, if I measure an elevated cytokine, and the higher it is, the more severe fatigue is present, that is already a quite good indicator that this also plays a role for the disease.
How much should we worry about possible confounders where, obviously you're going to try to match your control group to the long COVID group, right? Maybe you match by age, maybe you match by some kind of health status or whatever it is. But of course, it's hard to do all those matches perfectly, and you don't know all the hidden confounds. Like, for example, let's say that there were certain lifestyle or behavioral differences or psychological differences or anything like that. It seems like it could lead to false positives where you kind of attribute it to long COVID, but it's really just about the groups being different. Is that a challenge for this kind of research, or not so much?
Well, that is not so much here because we have so many patients and so many controls. Almost everybody had COVID. And of course, what is most important is that you can replicate such findings. So if one study finds this and the other study can confirm this, then you have much more confidence that this is a relevant finding. And we have several findings now where we have numerous studies confirming this.
Right, because it's such an evolving area. I mean, there are new studies all the time. But what are the sort of ones that have really been replicated where we're now really confident that there's a link between certain biomarkers or certain genetic tests and long COVID?
So I think the best evidence we have for immune dysregulation. So we have clear evidence that there is ongoing low-level inflammation. So we find elevated markers of inflammation. Interleukin-6 has been found, I think, in more than a dozen of studies. We find alterations in the immune cells. So we frequently see a pattern which looks like a chronically activated immune cells with activated T cells. We find alterations also in B cells, which produce the antibodies. We have several studies showing autoantibodies, and there is some evidence now that this is probably triggered by SARS-CoV-2 or by EBV proteins, and then can cross-react with own body structures. And EBV is one of the hottest candidates of triggering such autoimmunity. It is a virus which has long known as a virus which can trigger autoreactivity. It's also a herpes virus which persists after infections, which has been living with us for millions. And what we've learned is that in COVID, EBV frequently reacts, and that the risk of developing long COVID is strongly associated with EBV reactivation during acute COVID.
Is this similar what we find for other post-viral syndromes, or is this kind of a unique constellation of findings that make long COVID distinct?
Well, actually, there's a hypothesis that EBV is probably the cause of many of these post-infectious disease. First of all, we know that EBV by itself can trigger ME/CFS, which is a severe form of post-infectious disease. And then we know that EBV frequently reactivates when you have another infection. And that is because EBV persists in the B cells, and the B cells are the cells you always activate when you have an infection, because these are the cells making antibody, and every time B cells are activated and proliferate, EBV can reactivate.
And could you explain what is EBV?
EBV, Epstein-Barr virus, that's one of these herpes family virus, similar to shingles you mentioned, or herpes simplex virus.
I see. So essentially, these people already have Epstein-Barr, which is extremely common, right? But it's something about it getting remanifested in the body after COVID or after other viral infections. Is that what's happening?
Right. So every adult, or almost every adult, has EBV. You usually get it as a baby or early in childhood from your parents. Latest, you get it in adolescence. It's called kissing disease too, because you frequently get it from your first partner. And then in many, it's a quite harmless infection, which you hardly recognize. But especially when you get it later in life, it may be a quite severe infection called infectious mononucleosis, and there you have a quite high risk of developing post-infectious symptoms, and especially the risk of developing ME/CFS, myalgic encephalomyelitis, is quite high. So it might well be that at least a subgroup of long COVID is actually triggered by the EBV reactivation.
Okay, so COVID somehow is reactivating it in your body?
Yeah, COVID reactivates EBV, and then EBV induces the post-infectious symptoms. That's one possible concept.
As I understand it, many people with long COVID report PEM or post-exertional malaise. Is that a common symptom? And tell us what that means.
Yeah, that's quite frequent. Actually, I think it's among the top symptoms. So the most frequent symptom is fatigue. Fatigue meaning that you feel tired, exhausted all the time, although you have slept enough, although you haven't not overexerted. And exertional intolerance often goes along with fatigue, but means that you cannot exert as you used to. So already minor daily activity feel you pretty much exhausted. You're unable to do this. And post-exertion malaise is a special form of exertional intolerance, means that after minor activities, you not only feel exhausted, you feel terribly worse. So all your symptoms get worse, and this may last for days, and you may really be severely ill. And the post-exertional malaise is actually the key symptom of ME/CFS. So coming back to ME/CFS, I should explain it now.
Yeah, let's talk about what is that, and then we'll talk about how it connects. Yeah.
Yeah, so it's actually a disease we've known already long before long COVID, and it's now with long COVID also part of this long COVID spectrum, but not all patients with long COVID do have ME/CFS. So ME/CFS has several key symptoms. You always have the severe fatigue and the post-exertional malaise. And part of ME/CFS is also that you have cognitive impairment, which is called brain fog, and you often have easily pain in the muscles in the brain. You often have orthostatic intolerance when you get up. And this is actually a disease which it's well defined. So we have diagnostic criteria, and we know now that approximately 20 to 30% of the long COVID patients have ME/CFS, but we have many patients who got it already before the pandemic, followed by triggered by EBV or influenza, and then it's a long-lasting and usually chronic disease, and patients are usually quite sick. So many of these patients are housebound and have been suffering for decades. And until today, we have no real good concept how to treat it and how to help these patients.
So ME/CFS, I think a lot of people would have heard the phrase like chronic fatigue syndrome, right? That was sort of the older name for it. As I understand it, it's been kind of quite an intense history of people debating, well, what is it? What's its nature? Could you just tell us briefly about a little bit about that history?
Yeah, well, actually, there are reports more than 100 years ago about this disease. It's usually reported in certain epidemic situation. So, for example, in the US at like epidemic, and then many developed ME/CFS, or in London in the 50s, there was an epidemic in a hospital, and then many nurses developed ME/CFS. And for a long time, it wasn't really known what it is. And then there were, I think that was following the London outbreak, there were concepts developed that it's psychiatric disease, that it's a form of history, and one of the reasons was because it mainly affected females. And then there was a concept that these patients had illness disbelief, that they were just thinking they cannot exert. So they recommended treatment to convince the patient that they are not that sick and that they should exert. And this treatment concept called cognitive behavioral therapy and graded exercise therapy were then tested in clinical trials. And these clinical trials came out with a result that this is helpful in improving disease symptoms. And that was sort of the start for this decades of this concept that ME/CFS is a psychosomatic disease which you can treat by CBET and GET. However, patients said, well, this cannot be true. This is not my experience. I feel really not that I have a psychiatric disease. I'm mentally completely healthy. I just feel terribly sick. And also patients said that is nothing which helps me at all. If I overexert, I get a dramatic crash. And what then started was a reanalysis of these studies, and in the end, it came up that the results were inconsistent, that the patients included actually did not suffer from ME/CFS and so on. But these concepts were quite solid within the medical community for decades, and still until today there are physicians believing that it's psychosomatic disease, and that is probably the main reason why we until today haven't adequately done research to understand the disease, and why we never have really had the chance to develop curative drugs.
So you think that the psychosomatic view of it kind of held back the research development?
Yeah, of course, because why should governments give funding to a disease which is psychosomatic, where we have already concepts to handle it?
How similar is are the symptoms of long COVID to ME/CFS? I think you said about 20% of people will meet criteria for ME/CFS who have long COVID, but are there other connections, or is it just that a subset of them will have ME/CFS?
Well, many symptoms overlap. So fatigue and brain fog and orthostatic problems are very frequent in long COVID too. So I think there are many similarities in a major subgroup of long COVID with ME/CFS, and the disease ME/CFS is not so clear defined until today too, because there are different diagnostic criteria. In Europe, we use other diagnostic criteria than in the US. So according to the US criteria, about half of long COVID patients have ME/CFS. If we use the stricter European criteria, which are usually the Canadian consensus criteria, then it's only about 1/4 of the patients. In UK, they have other criteria. Again, they have the NICE criteria, which are closer to the US criteria.
Interesting. So it sounds like it's still evolving.
Yeah.
And for studies like that, how do they define who has long COVID? Because that seems also a little bit unclear.
Yeah, that is again that we have different diagnostic criteria. So we have criteria which include everything which can be triggered by COVID. So COVID, for example, can also trigger known diseases. So we know that almost all autoimmune diseases are more frequent in the year after COVID, but also cardiovascular diseases. And then we have these patients who had severe COVID, were on the intensive care unit, had thereafter lung problems. And this, according to broader definitions, is also termed long COVID. But I think the WHO definition is more helpful because it only includes those patients where we cannot explain the symptoms by an alternate diagnosis. And I think that is the group of patients which is first of all the largest and which secondly is not fully understood now, and in which we really need to find good concepts and develop therapies.
You mentioned subgroups earlier. I mean, it sounds like the definition of long COVID is pretty broad, right? Because you're essentially getting symptoms after COVID. The symptoms can't be explained in another way. But of course, it could be that it could be some percent have some other disease that's just not being identified, or that there's some other factors. So is it really makes sense to think of long COVID as one thing, or do we really need to think of it as like there's multiple possible situations going on here?
Well, I think we need to think of different subtypes. That is not only important for diagnosing, but of course also for treatment. And as long as we do clinical trials, just including everybody according to the post-COVID definition, I think we are too broad, too unspecific. And that's what we've learned during the last 2 years from clinical trials. So several clinical trials turned out to be negative. So the drugs which were tested had no effect on the disease.
And what were those drugs?
Well, there were several drugs tested so far. There were drugs targeting virus itself. So Paxlovid was tested in 2 randomized trials and came out negative. And then there were also several drugs, several supplements given to see if one trial, for example, tested vitamin B3 and this came out negative, or there was a trial testing an anti-inflammatory drug called colchicine, which was negative. The major problem of these trials is they did not include the patients who really had evidence of viral persistence or evidence of inflammation. And as long as we do these broad trials, it's probably that we miss a subgroup of patients who may benefit from this treatment. So the next step of therapies we at least in Germany do now, and probably worldwide, is that we now do it in subgroups, which are defined by biomarkers, or which are also defined by clinical subgrouping. For example, we do clinical trials now just in the subgroup of ME/CFS patients, which can be defined much better and which we think is more homogeneous mechanism-wise.
So if we think about everyone who's diagnosed with long COVID, right, some percentage of those people will be misdiagnosed, right? That will happen for any disease, but especially a disease that has sort of fuzzier boundaries. And some of those patients may have this sort of ME/CFS sort of subtype. And then some may have some other version of it. Do we have any sense of like the relative proportions of, how many people do we think might be misdiagnosed versus might have this ME/CFS subtype or versus other subtypes? Or do we really just not know at this point?
Well, if we use this broad definition, there will of course be patients who in the end have developed a disease which was not triggered by COVID. So they had just COVID in that time, but developed something else. Of course, this is quite likely. But on the other hand, many of these patients are quite young. So there are many people who have been completely healthy before they developed the disease. So I think in general, these cohorts are quite well defined, even if you have probably 10% of patients not being real long COVID cases.
I see. And then what about the other subtypes? Do we have any sense of how common they are, or really it's too early to say?
Well, for ME/CFS, I think it's roughly 1/3. And then we have another diagnosis we know already, and that is called postural tachycardia syndrome. This is a disease where your cardiovascular regulation is disturbed. It's often a more general disturbance of your autonomic nervous system. So that is the part of your nervous system which works in a remote fashion. So it controls in an auto modus that you breathe, that your heart beats, how you distribute your blood. And this is severely altered in a subgroup of patients. And the postural tachycardia syndrome is a clinical definition. So patients who have symptoms of orthostatic intolerance, who get dizzy when they stand up, and when their heart rate rises above a certain level, this is called postural tachycardia syndrome. And there we have another well-defined subgroup, which is probably again 20% of long COVID patients. There is some overlap to ME/CFS too. And then I think there are about 50% of patients where we have no clear diagnostic criteria yet. But again, we have already distinct subgroups we can define, for example, those with severe neurocognitive impairment. You can measure by certain testings. And this is definitely a group which also needs a better development of drugs, because this can be defined, and we have already good concept that there probably neuroinflammation is ongoing or impaired perfusion of the brain, which may then be targeted by respective drugs.
You mentioned tachycardia syndrome. Is that what people call POTS?
Yeah, POTS, postural tachycardia syndrome, or POTS.
Right. And sort of a typical symptom of that would be after standing up, you might get lightheaded or have a funny heartbeat, things like that. Is that correct?
Yeah.
So something that I find a little baffling, and you're an expert on this, I'm not an expert, but it really confuses me, is that there are some people who have gone and done interviews with people who've recovered from long COVID, and I don't know, and also ME/CFS, they've done interviews with people who recovered, and I don't know how strict their definitions are. They're probably not very strict, but you could find there are literally hundreds of these sort of people who say, okay, I had this and I recovered. And if you look at those case reports, many of them report that psychological methods essentially helped them or even cured them, which I find very strange. And I don't know whether that's because there are psychological methods that could help people with these medical disorders, or if there's some subgroup where it is more psychological and not sort of more medical. And I'm curious what you think of that, what you make of that.
First of all, of course, long COVID can heal out. So we know for sure that within the first month, a lot of people get better and get healthy again after having long COVID.
Well, would that even be long COVID at that point? Because don't they
Well,
have to
but
have
per
it for
definition, it's long COVID, and then
I see.
especially
But in the
during
coming months,
the first 6 months, and then you can get much better and become healthy again. But that
Right.
was long COVID. That has been shown in several studies. On the opposite, if you have been ill for more than 6 months, then the risk is quite high that you remain ill for longer. Although we also know well from clinical trials that you can also recover after 1 or 2 years. So it's not automatically a chronic disease. With ME/CFS, it's unfortunately comes along with a very high risk of a chronic disease. So what we've seen in our studies and several other people have seen is that the risk that you remain ill is quite high, so 90% or higher. So I know these reports. Some patients, first of all, do recover. That's what we see in our studies. And then what is the role of psychology in these diseases? It's, of course, not the cause of ME/CFS, but it's definitely a consequence. So if you are so severely ill, and if the situation is so frustrating and with so little perspective that you, of course, are distressed, and that some patients need psychological support, that is evident. And that in some patients, this psychological support also helps them to manage their disease better. That is common sense too. But that you can cure ME/CFS just by psychotherapy, I still have no evidence that this is the case. And of course, then we have a situation where you really don't know if the diagnosis was right in these patients, because here we have a problem. ME/CFS is still not that well known among physicians. Before the pandemic, there were, I think, many physicians worldwide who have never ever heard of ME/CFS. And still now, after 5 years of having faced long COVID, there's still a lot of uncertainty in several medical communities to diagnose long COVID properly, to diagnose ME/CFS properly. And what is terribly confusing is the name chronic fatigue syndrome, because fatigue is a very common symptom of many diseases. Or you can have fatigue without any obvious cause. You just feel more fatigued, more stressed, more exhausted. That is quite common nowadays. And then if you do not know the disease some physicians and also some patients tend to call that disease chronic fatigue syndrome. And that is probably a major problem of these confusions. Mm-hmm.
Right, because they might just have a lot of fatigue and then it sort of fits, but
they do not have chronic fatigue syndrome. That is a different condition. That is a very severe, complex disease and has nothing to do with just being fatigued.
So on the psychological front, obviously this is a difficult topic to talk about, but one possibility is that there are patients who could be benefited a lot from therapy or from psychological techniques, even if it's not the cause of the problem, and even if it doesn't cure them, right? It just could be helpful. Yeah. And, cognitive behavioral therapy has been used for many different disorders of all different sorts and I think many people have found it helpful as a way even to live with difficult challenges. So I'm wondering, I know that some early trials were done on cognitive behavioral therapy for these conditions. And what do you think about, what is the current state of evidence? Is cognitive behavioral therapy helpful or not so much? Even if it doesn't cure anything, or even just as a way of helping you deal better with your symptoms? Yeah.
The question is, what is cognitive behavioral therapy? So there is not, that is just a a term for many different approaches. So the strategy may be that you have chronic pain and that I try to help you to cope with it and to learn certain strategies. But in ME/CFS, for example, cognitive behavioral therapy was to tell the patients that they can do these things as they did it before, so that they just have to believe that they can do it again. And that
To
is
push them to do all the normal behaviors, even if they say they have horrible crashes.
and that is very
I see.
dangerous. And what is the right term is actually not cognitive behavioral therapy, but that you have supportive psychotherapy, so that you really support the patients in the daily needs and problems. So, for example, help them to find strategies how to live with the disease, how to manage also the emotional problems that come along with the situation, or how you can how can you learn pacing? So pacing is actually a major challenge. Pacing means that to avoid post-exertional malaise, you have only a very limited amount of activities which are possible during the days. So you have to make decisions that you probably have just an hour per day in which you are active. And then you have to decide how to use this hour. And that often means also that you have to say no, and that you have to say to your children, no, I can't play with you, and so on. So this is also something which is a major challenge. And for this, such an approach of supportive psychotherapy may be helpful.
I see. Right. Right. Because as you point out, I mean, cognitive behavioral therapy could mean many things, right? It could, I mean, a lot of cognitive behavioral therapy is about getting people to think about the way that they're interpreting events and saying, is there a more helpful way to think about this, right? Like, for example, I imagine people who are suffering from these disorders, it's very common that they lose all hope. They think my life is over. I can never enjoy anything anymore. And you can imagine the therapy being helpful to help say, okay, you can still have some meaning in life, some value in life, and help them be less depressed or less anxious with the exact same symptoms, right? Versus telling them that, no, actually, you just need to push through. And if you just push through, you'll be fine.
Yeah, this is the concept, right?
So I've looked at a lot of interviews and case reports of people who say that they had either ME/CFS or long COVID and then say they got better using psychological methods. So I've looked at many of them. And one thing that I notice is the pattern is not so much the CBT-like exercises that they say help them. Largely what they say help them is learning to interpret their symptoms differently, right? They noticed that they were having a kind of fear reaction to their symptoms or viewing their symptoms as really bad. And that it was more through learning to like view their symptoms more with equanimity, where they're sort of learning to sort of not react to their symptoms, that they found that that was like life-changing. And I wonder, has a study ever been done looking at this kind of question of like how people view their own symptoms?
I think what you are referring to are techniques which are called lightening or Gupta program.
Tons of names for these, yeah.
Yeah, that you just say yourself several times a day that I feel okay and the situation is not so devastating and I have to be positive and so on. And actually, this is dangerous because this is also emotional stress, and it doesn't work. At least in the large majority, it doesn't work at all. And I don't think that there are any high quality studies really confirming that this is working in a subgroup, or the other interpretation we had is that it's really probably patients not having the diagnosis or having a very specific form with an ME/CFS-like picture, but probably another pathomechanisms.
Okay, so maybe there's some subgroup that has similar sort of symptoms that is benefited from these techniques, but they're not. This is not the patients that you're treating in your trials. This is different, some kind of different group, but they kind of have similar enough symptoms that they get bucketed the same. Is that kind of the idea?
Yeah, that is right. And what is really the dangerous thing about this concept is that it's also a matter of being responsible about your disease, and that it's your fault that you do not get healthy because you are not trying hard enough.
Yeah, well, I'm not an advocate for any particular viewpoint, but I think the people that do advocate for this, they would say it's not that it's your fault. It's that you've learned a kind of fear response to your own symptoms, and that by learning to have a more equanimous reaction to your own symptoms, that actually will cause the symptoms to go down. The most scientific viewpoint I've seen put on this, and I'm not saying that this is a scientific viewpoint, but in the pain reprocessing therapies for chronic pain conditions, there is some evidence, and there is at least one randomized control trial looking at getting patients to view their pain symptoms differently. And there's some evidence, at least, that if you have a chronic pain condition, but there's no organic disease, like let's say you have low back pain, but on MRIs and stuff, there's no sign of disease, that patients can learn to view the pain symptoms differently, and over time the pain might fade. So I guess that's maybe the most scientific way of looking at it that I'm aware of. What do you think about that?
Yeah, I agree. Although I'm not a specialist for CBET, I know that this is working, and that makes sense. And this is very different from a disease like ME/CFS.
I see. So just a different kind of category. That makes sense. You mentioned physicians, and I imagine a lot of people who have ME/CFS or long COVID that go to a regular general practitioner. I imagine the GP doesn't necessarily know what to do with them. What kind of experiences are people typically having when they go to their GP?
Well, there was a recent study in Germany asking long COVID people about their experience, and there's still that many report that they feel not taken seriously. They experience a lot of psychologization, we call it in German, so that their disease is interpreted as being psychological. And many also say they feel stigmatization due to this. And this is, of course, getting better. I know this because I have been taking care of ME/CFS patients for almost 2 decades, and I know the situation before the pandemic was much more difficult. Then really many physicians didn't know the disease. Nowadays, I think almost all physicians, and now I'm talking about Germany, where I know the situation best, know the disease, but still there is great uncertainty how to help these patients, how to diagnose, how to treat it, and therefore we think it's still important to have public awareness, have ongoing public awareness about the disease, and also offer education so that the physicians learn how to handle these diseases, and that we also need guidelines, which really is the way medicine works nowadays, that you have guidelines for all diseases which tell you how to diagnose, how to treat it. And that has been largely missing before the pandemic for ME/CFS. Now we do have guidelines for long COVID, for ME/CFS, and that at least helps that patients can get now their basic treatments. So many patients suffer from symptoms which are not so difficult to handle. So sleep disturbance, pain, orthostatic intolerance, these symptoms can all be treated by drugs which are available, which are licensed, and which can be prescribed. And that is the current situation, that we really try to bring this to the physicians and to the patients, so that at least the care for the patients in general gets better. That's the situation at the moment, and the situation for the future is that we really develop drugs which target the disease mechanisms and which bring us a promise that we can effectively treat and cure these diseases.
Right now, as I understand it, all the treatments are essentially treating symptoms. Is that accurate?
Yeah, more or less. So many of these drugs we have just treat symptoms. For example, fast heart rate or sleep pills are frequently used now, drugs to treat these symptoms. But we do already have some drugs which can also treat mechanisms. These are usually off-label therapies, so they are not licensed for ME/CFS or long COVID, but they are used and prescribed by some physicians, and the most frequently used drugs like low-dose naltrexone or mestinon, they are all currently tested in large randomized trials. So I think that within 1 to 2 years we will have definitive results. If they
Oh,
are
great.
active and in which subgroup they are active, and then we have also good chance of having the possibility to prescribe these drugs. Although these drugs in general are not curing the disease. So we know that a subgroup of patients can get much better with these drugs. But what we really need is a drug that can cure the disease. And I'm convinced that we actually do have already these drugs, because we have these drugs already in use for many other diseases. And what we need now is we just need to really understand which are the right drugs we need to develop. And then we need to do the clinical trials to get clear evidence that they are effective and in which subgroup. And then in the end, we need to have these drugs licensed and can be prescribed.
That's fantastic. So it sounds like you're optimistic that some of these new trials that are going to come out in a year or two, like on naltrexone, will actually find positive effects.
Well, I'm pretty sure about naltrexone. So we have been using it for years, and we know it's quite effective in a subgroup. And then our research, our main interest is autoimmunity, autoantibodies. We know that in a subgroup of patients, we most likely have an autoimmune mechanism. So it's an autoimmune disease like many other diseases which are autoantibody mediated. So we have many diseases nowadays, rheumatoid arthritis, multiple sclerosis, and so on, which are autoimmune. And for these diseases, we do have several very good drugs. And we got funding in Germany since 23. We are doing clinical trials here. And we do have already good evidence that in a subgroup of patients that the removal of autoantibodies is effective. So the first trials we did were with immunoabsorption. That's a technique with which you can wash out all antibodies. And then when patients get better, you know that this must be the antibody you removed. This is no curative therapies, because the cells producing these antibodies, they still stay in the body. But the next step is now that we do clinical trials with the drugs, which we do already have from other diseases, which delete these antibody-producing B cells or plasma cells. And that is what we are currently preparing. So we are ready to start with 2 clinical trials end of spring.
Oh, that's fantastic. And so the hope is that could lead to a true cure for the disorders.
Yeah, so we are pretty sure that this is for a subgroup an effective treatment.
And is that the subgroup that also has ME/CFS?
As we have been doing research on ME/CFS already before the pandemic, this is still our main focus.
Oh, okay.
So we are currently doing these trials in ME/CFS patients who developed ME/CFS following COVID or other infections. This is about probably not only restricted to ME/CFS, because we have evidence also that in post-COVID in a subgroup, it's autoantibody mediated. There are 2 very important animal models performed. One is performed in Yale from Akiko Iwasaki, and one in Netherlands from Jeroen den Donnen, and they isolated the antibodies from patients, and they transferred these antibodies to the mice, and then the mice developed very similar symptoms. And they also showed that these antibodies from the patients, they bound to, for example, neuronal structures, and this was associated with the symptoms in the patients and in the mice. So this is pretty convincing data that is also a relevant mechanism for a subgroup of long COVID patients not having ME/CFS.
Now, why would a drug like naltrexone help? Like, I think they've heard of that maybe as a drug for alcoholism or opioid use disorder.
Naltrexone has several interesting mechanistic effects. So what it can also do is it can ameliorate inflammation. So it inhibits an important ligand, toll receptor 4, which is a trigger for activation. And it also influences an ion channel, which we know is impaired in function in ME/CFS and long COVID, and it was shown, at least in vitro, that naltrexone can restore the function of this ion channel and thereby restoring the immune function and probably the function of neurons.
So it basically has nothing to do with the mechanisms for alcoholism. It's a completely different use.
Well, that's not really it's also a concept that it may also upregulate the receptors for opioids, and that it's known that we also produce opioid-like molecules in the body, and they may therefore be more effective, and therefore we may have less pain. That is also a concept for the treatment with low-dose naltrexone.
Ah. And what about post-exertional malaise? Is there any known treatment for that?
Well, if we can treat post-exertional malaise, we probably have a drug which can treat all patients suffering from post-exertional malaise. It may probably be triggered by different mechanisms. So therefore, there are also scientists trying to develop drugs which can directly inhibit the development of post-exertional malaise, because post-exertional malaise is not present all the time. So it comes and goes from time to time, and therefore it could be sort of a preventive treatment. And what we know, what in the end is post-exertional malaise, most likely it's that you upon exertion do not adequately perfuse your muscles, because that is disturbed in many patients, in all patients with ME, CFS, and long COVID, that your autonomic nervous system is not properly working. Now, if you exert, if you start to run, you need much more blood in your muscles. And if you cannot open your vessels adequately because your autonomic nervous system is not working properly, or because your vessels are inflamed, that is something we know is quite frequent in long COVID, then your muscles do not get enough energy and oxygen, because that is in the end what you need to make energy. You have mitochondria in the muscles, and these mitochondria make your energy. They make it from oxygen, from the blood, and from sugar or proteins, and then without enough oxygen, you cannot make enough energy, and then you very rapidly develop muscle aches, and you use up your sugar in a form which is inefficient, so-called lactate, and that produces a lot of proteins and makes the muscles acidic. And so after exertion, you need to get rid of these protons, and then you need your ion pumps, and that is a quite complex and energy demanding process. And in the end, this is probably what makes post-exertion malaise, because your muscles get so severely damaged in the end, because you cannot recover your muscle into a normal state. It's probably like if a healthy person is running 20 miles, that is what happens in the muscle of somebody with post-exertional malaise after walking 400 meters. And if we have a drug which can improve perfusion, or which can avoid these alterations in the muscle, that would be a drug which can prevent PEM. That's quite complex, I know. It's difficult to explain it in simple words, but there have been several reviews already written about this topic. So for those who are interested in more details, I can give you the literature.
Yeah, that'd be great. We could put it in the notes. Is it understood why the post-exertional malaise can be so inconsistent, where maybe the patient will, walk for 20 minutes and then 3 hours later they might have a crash, or 5 hours, or maybe even the next day?
That's probably due to what I just tried to explain, because it's what we know too when we run too fast. The muscle pain will be worse at the next day.
Oh, I see. So it's a similar mechanism of why it's delayed. As long COVID was beginning to be understood, people started getting really concerned that this might become a major percentage of society that eventually gets it, right? So if every time you get COVID, there's some chance you're rolling the dice that you might get long COVID, then you might think that just over time, more, COVID's still running rampant in society. You might just get a higher and higher and higher percent of people that end up with long COVID. What's our current understanding of that? Like, do we expect that we're kind of at peak long COVID, or do we expect it to continue going up in society?
Well, the bad news is that you can still get long COVID, even if you had no problem after your first or second infection. That's what the studies tell us now.
Do we expect it's less likely, like if you've gotten COVID once and didn't get long COVID,
Uh,
and then you get COVID again, do we think you're less likely to get it the second time?
You're less likely, but you still can
Yeah.
get it, and so
Okay,
on.
got it.
So, and there was a recent study in children, which already even showed that the risk is similarly high from infection to infection.
If it was truly similarly high, though, wouldn't just sort of everyone eventually get it? Like, I mean, I assume I probably get COVID like once a year, I assume, right?
Well, so at the moment, I think we have numbers which are no longer increasing, but they are also not decreasing,
Hmm.
because many patients stay ill for
I see.
a long decade, and then there are new cases coming. But the risk of developing long COVID in general is much lower nowadays than it was in the early days.
Is that because the severity of the virus
First of
kind of
all,
became less severe? Yeah.
yeah, that the virus Omicron is less severe, and then of course we are vaccinated, and we our immune system is trained. All of us have had at least once COVID so far, so the risk is much lower nowadays. On the other hand, we do still also have the risk of developing post-infectious diseases triggered by other viruses. And we have, during the last 2 to 3 years, we have quite a high number of other viral infections too. So we still see many, many patients with new infections triggering long COVID or post-infectious diseases. That's true this winter, that was true last winter. So this is still a time where we get many patients developing newly these diseases.
Is there an estimate of, if you get COVID once today, what the chance of getting long COVID is from that?
Well, there are several studies, and the numbers vary, but in the beginning it was about 10 to 20%, and now
Oh my
it's
gosh,
it's much lower. So yeah, probably with an average of 1 to 2%. I think that's a good estimate.
that's still, pretty high. And what do we think the current prevalence of long COVID is? If we look at, across society, what percentage of people have it right now?
There was a large review, meta-analysis of the major cohort studies from Ziad Al-Ali, who is a renowned epidemiologist in the US, and he came up with a number of 5% for 2023.
I
5%
mean,
of the world.
I mean, that's massive. 1 in 20 people have long COVID. Yeah,
Of course, doesn't mean that they are all severely sick,
right.
but it means that these patients have lingering symptoms. And if we look around and the people we know, I think almost everybody knows somebody who has still problems from COVID. I think it's a realistic number, at least to say that there are a few percent of the population still suffering from long COVID.
And is it roughly static now? It's been about 5% for a while, or are we seeing that number go tick up or tick down?
Well, it's I think that at the moment we have static number. That's what the studies tell us.
And what about ME/CFS? Do we have a sense of what percentage of people have that?
Well, there were fewer studies about the prevalence of ME/CFS because, as I said before the pandemic, there were few scientists interested in studying ME/CFS. And the estimate before the pandemic were about 0.15 to 0.3% suffering from ME/CFS. So in Germany, with 80 million people, these were estimated 150,000 to 300,000. That was quite a number. And now there is good evidence that numbers roughly have doubled as a consequence of the pandemic.
Interesting. I would have thought it'd be even more than that if 20 to 30 whatever percent of people with long COVID get ME/CFS. I would have thought 5% of people had long COVID. You'd be seeing higher numbers.
And it again depends which diagnostic criteria you use. When you use the IOM criteria, you have higher numbers of ME/CFS patients compared to the Canadian consensus criteria. So there's a large German study using the Canadian consensus criteria, and there we had 10% of ME/CFS patients.
I know at least two different unrelated people who currently still take great precautions to avoid getting COVID, meaning they make very significant changes to their life to avoid COVID because of concerns about long COVID. What would you say to someone who's doing that? This is being recorded here in 2026.
Well, first of all, it depends on your personal risk. If you have had already long COVID, of course, you are at a higher risk to get it again with another infection. Then I also would recommend, for example, to wear masks when you are in public transport.
If you've had it previously. Yeah. So in this case, neither of them have had it previously. They're just concerned about it.
Yeah. We also have patients who are at a risk because of immunodeficiency. So these are the patients we also recommend to be very cautious and to wear masks. To put it more general, we know that there are people at higher risk. We know that female in general have a much higher risk. So 80% of our patients are female. And we know that obese patients are at higher risk. We know that patients with other immune diseases like asthma, allergies, autoimmune diseases are at a higher risk. But the problem is, what would happen when you wear a mask all the time? And what we also learned from the years 21 and 22 is that by wearing masks all the time, then later on you have a higher risk of getting other infections because you not continuously train your immune system. For example, the respiratory syncytial virus, which became much more frequent than in younger children.
So you might be actually weakening your immune system by doing that.
So probably your immune system is not made to be protected all the time. So if you otherwise are immunologically healthy, I would not recommend to protect yourself all the time. So for example, I use a mask when I'm in contact with people who are obviously having an infection, or if I go in public transport and it's very crowded, then I take my mask and protect me. But I don't use it all the time. And that's probably a good advice on how to handle it.
We know that with COVID itself, age was an incredibly huge risk factor, right? Your risk of dying if you were 80 versus if you were 20 was just kind of almost unbelievably different. Is that also true of long COVID?
Well, but we have other risk factors. So the risk of dying, the older you are, was most likely to a weaker immune system. And we also know that men were at a higher risk of dying because men in general have a weaker immune system. And the opposite is true for long COVID. There we have the younger patients with a stronger immune system, the females.
Oh, I see. So we think it's because sort of the immune system's overreacting. So it's sort of the opposite of what was happening of patients dying of COVID, where it was a weak immune system caused you to die. But overactive immune system might cause you to get long COVID. Is that accurate?
Yeah, exactly. Mm-hmm.
Oh, that's fascinating. That's kind of flipped on its head. What about vaccines? Do we know that they reduce the chance of getting long COVID?
Yeah, we know it. There are many studies providing proof that you reduces the risk. Unfortunately, it's not 100%. That was the hope, that you can protect yourself very efficiently. And the numbers are about 50%, though the risk reduction is about 50%, which still is a lot. And we know, of course, that vaccination also protects from the more severe courses. So the recommendation is to get vaccinated if you are in a risk group. So that means above 60, you should get vaccination. And we also recommend a vaccination to our patients where we know that they have a high risk of developing long COVID, or especially the patients who have already long COVID or ME/CFS, who have a risk of disease deteriorating with another infection.
Has it been shown that people with immune issues prior are much more likely to get long COVID?
Yeah, if you have a more active immune system, or if you have a certain type of immunodeficiency. So there are several forms of immunodeficiencies we know which go along with a higher risk of developing long COVID.
And suppose you get long COVID. What is the progression of it? Does it tend to sort of slowly get better over time? Does it kind of just stay static for many people? And sort of, do most patients eventually recover after a certain number, after a number of years?
Well, we have different courses, as you describe. In some patients, it's get better. In some patients, it may get worse. Some patients directly get sick, so they have COVID, and then it's a continuum into long COVID, and other patients recover, and often it's in the situation that they go back to work or that they go back to sport, and then they get worse again. And then we have fluctuating courses. Some have better months and worse months. And of course, we have the patients who recover, especially early during the first month of disease. And then, unfortunately, we do also have those with the severe and chronic form.
So it sounds like a really wide range of possible outcomes. What is, let's say someone gets long COVID, do we know the chance that 3 years on they are kind of completely better?
Well, difficult to say, because long COVID is so different from patient to patient, and we do not have good prognostic factors yet. We also
Okay.
tried to find prognostic factors, so we started in 2020's large observational study for long COVID and ME/CFS patients. And one marker which came out as being a prognostic is the hand grip. So that is an indicator of how strong your muscles are. And if you have
Hand grip strength.
bad hand grip early on in the disease, you have a high risk of a severe and chronic course.
That's a funny metric because that's also been found to be very linked to longevity and other things like that, right? But I think I presumably we assume that it's not a direct link. It's some kind of indicator, right? It's not like if you make your hands really strong.
Probably of your metabolic health as well, which is influencing the strength of your muscles. So if you just regularly train the strength of your hand, that does not necessarily mean that you live longer.
Do we know at least if the majority of people with long COVID will eventually get better, or do we not even know that?
Well, when we look over the last 3 to 4 years in which we follow now the patients, those patients we follow in our cohorts are those which either have developed ME/CFS or at least have a form of long COVID which goes along with fatigue and exertional intolerance. And there we found that those with ME/CFS, the risk is less than 10% that they recover over this time. And those who do not fulfill the criteria, there we have a higher chance that they get better over time, but still there's also a high number that they remain sick. And there was a recent study published from Recover, that is the US group studying long COVID, and they also showed that there's approximately a group of 5% of patients who stay chronically ill for years.
Sometimes people will refer to chronic Lyme disease as one of these conditions that they'll kind of group in a similar category. In fact, funnily enough, I was actually diagnosed with chronic Lyme disease when I was a child, and I went through intensive treatment where they gave me like antibiotics for a month intravenously, which my understanding is that's not even considered, many people consider that not a legitimate treatment now. But anyway, that was my own experience. But I'm curious, would you group chronic Lyme disease in the same sort of set of disorders, or do you think that's really just unrelated, something different?
Well, I would group it into this diseases, but there are some specific things about chronic Lyme disease, because we know that there is a group of patients where it can persist. The Borrelia burgdorferi, which is the bacterium causing the disease, and these patients can be treated by antibiotics, though it can persist in the skin or in joints, and then it's treatable. And then there's another group of patients where we have no evidence of persistence of the bacteria, but who still are very sick, and this probably is more likely what we see with ME/CFS or long COVID, where we have a disease which was triggered by the infection, but which becomes independent of the initial trigger.
And I guess in this case, it's a bacteria rather than a virus. But for that group, are the symptoms fairly similar?
The symptoms of Lyme disease are also very similar. So they also suffer from severe fatigue and cognitive impairment, myalgia. So this is similar.
Before we wrap up, I just have a few more questions for you.
Okay.
The first is, what advice would you give to someone who has long COVID or ME/CFS today? Like, what should they do?
Well, I get this question asked several times.
I'm sure you do.
What we did is the problem is that we have still few specialists. So many patients need to rely on their primary care physician, and we have at our center we have a website on which we provide a lot of information for patients and physicians. So we have a guideline how to diagnose and treat ME/CFS, and we also have guidelines for long COVID. So I recommend the patients that they should tell their physicians where they find this information, and I tell the physicians that they should just proceed symptom-wise. So ask your patients what are the most worrisome symptoms, what would you like to get treated first, and then do a stepwise treatment. And then self-management is important too. So for those suffering from post-exertion malaise, the strategy of pacing is very important. That is not so easy to understand and to handle. So there's information material also available on our website, but I'm pretty sure that you can find it also at several US institutions, and there are also self-help groups in the US. And there are also strategies which may be helpful, like certain breathing techniques, like certain techniques of relaxation. You may also find strategies to handle certain intolerances. So many patients also suffer from allergy or food intolerances and so on. So there's a lot you can do, and there's a lot of information around. There are many very well-informed patient organizations with this disease, and I recommend that you should also look to have contact to these patient organizations and to get information there. And then, of course, there are a lot of social problems coming along with having such a severe disease and being sometimes unable to work or only part-time. And that is also very helpful to exchange with these patient organizations to find a way how to handle this.
We'll put links in the show notes to your website with that information.
Yeah.
And suppose that it's not you who has long COVID or ME/CFS, but one of your loved ones does, right? Your child or your husband or your wife or your mother. What would you advise in that case?
Well, difficult question, because it's always difficult to handle diseases in your family. What I advise my patients is that we would like to treat everybody in a clinical trial. If we have no curative treatment to offer at the moment, we should try to treat as many patients as possible in clinical trials. And one prerequisite is, of course, that we have the financial support to do these trials. But we are now in a situation that this much improved. I think a situation is similar in the US. There are also several research consortia now performing clinical trials. And that's what I recommend all patients is to participate in these trials. And even if you would get placebo, because that is what is typically done in a clinical trial, so only half of the patients get the drug, the other half gets the placebo, we still learn a lot. So if this drug is effective and you have just got placebo in the end, you may get the effective drug too, because then there will be a next trial, or it will be licensed in the end. So that is what I would try to offer every patient, not only my family.
And then how about on the sort of the psychological front? Because I imagine it can be quite difficult. Your loved one might be sort of essentially disabled from one of these conditions. Do you have any advice there?
Yeah, that is really terrible to see how much these young patients suffer. We even have children suffering from these diseases. And to help these, we try to build up really a network so that we can offer psychological and psychotherapeutic support for everybody. And in Berlin, we got funding to build up a care network. So we work together with primary care physicians who develop experience in treating these diseases. And we also work together with a network of psychotherapists providing psychosocial support for these patients. And we hope that in a few years, we have such a structure in Berlin that every patient developing long COVID or ME/CFS get an early diagnosis, get adequate symptomatic therapy, get adequate support, and that we can, in the end, cure all these patients.
That's a wonderful goal. Final question for you. Suppose you had unlimited money to run one study. What's your dream study that you wish you could run on these relevant questions?
Well, I'm pretty much convinced that a subgroup of these conditions is autoantibody mediated, and we have very effective drugs nowadays. And actually, my dream comes true because we got now funding to run two trials. So we will not. So my next hope is that we get these studies done as fast as possible. These are quite demanding nowadays to do clinical trials. All these regulatory and data protection rules. But if we can do these trials as fast as we hope, then we may have results end of next year.
Wow, that's fantastic. Well, great news. I'm really excited to see how that turns out. Hopefully you'll find a cure. That would be incredible. So, Carmen, thank you so much for coming on the Clear Thing podcast. This was so informative.
Yeah, thank you very much that you make this podcast about this important topic.